Good morning. I am just reporting on how to open up and how to document on a progress note. So this is something that we went over in new hire orientation, but there's a couple of questions, and I know that when I walk you through step by step and it takes 2.5 hours, that sometimes we forget how to document. So I just wanted to go through this with you. I actually made a video about an hour and a half ago and spent that much time on it, and it came out quite skiwampus. So we're going to start again and see how that looks. So first, how we're going to write a progress note. So we're going to log in to the clinical notes. That's where we want to be at. And so when we log into the clinical notes, we're going to choose the NP clinical note. And so once you click on this, it will give you this screen, and we have the option of creating an initial note or a follow-up note. So we want an initial note. So our first note will be an initial. And so we're going to click on the initial note. And when you click on it, it will give you this screen, and it will show you select initial note or create a new. And we're always going to create a new for the first time we see the patient. When the patient comes back from the hospital, when you're doing your routines, there'll always be a follow-up, but one initial and then never another initial will be needed. And so then you're going to come to select patient. And when you're selecting the patient, you'll see this blank spot of provider. And then this is where you're going to select it. And you're going to click this little magnifying glass. Once you click the magnifying glass, it will open up this box. This box is where we're going to search by patient first name and last name. So usually you can get away with just using a couple of initials. So maybe John, you could just put J-O, and then Smith, S-M-I, but you might have to type out the whole name as well. And once you've put your patient's name in, you're going to click this button right here, which is the search button. When you go to search, it's going to bring up all of the patients that you have. So if you have like a John Smith, there is a high potential that you're going to have to figure out which John Smith it is. So I just picked a demo patient, and there's two of them in the computer. One that has a birth date of 1947 and one that has a birth date of 2000. It is very important that you're looking at point-click care and making sure you're picking the right patient, because that doesn't only affect your billing, but it affects where and what chart this note goes into in point-click care. So when you've decided which is the correct patient, you're going to click the select button. So when you click the select button, then now it's got your name on it. It's got the patient's name on it. It's got the facility as well as their date of birth. So that's what you want to have happen once you select the correct patient. At the bottom of this right here will be the date of service. So we're asking that you open up your notes within 24 hours and then submit them within 72 hours. So your date of service should be today, but if you didn't finish yesterday and you're going to open it up for yesterday's date, because that's the date of service. And then you're going to save that as a draft. Once you save it as a draft, your whole note will open for you and you're ready to begin. So again, open within 24 hours, submit within 72 hours. So you see a patient on Monday, you submit the note on Friday. In point-click care, it will be under Friday's date, the submission time. So when you submit it, it looks like the patient is here, but point-click care is chronological, so it won't really look right where it's 5 days late, and this is what actually happened here. So it's really important to get that note in a timely manner so that you're following that plan. So how do you fill out your progress notes? So once you open it, there's this green bar on the top right-hand side that fills in the point-click care data. That is a very important button because it pulls a lot of information from point-click care. And then you'll also notice with your note that each section has a header. And if the section has a red asterisk, then it's required for you to complete before you submit. If you try to submit and that box has nothing in there, you won't be able to submit. And then some boxes, some sections have this blue eye, which is information on what is required in that box. And so you can just hover over that and it will open up what is required in that box. So the chief complaint is required. If you come in here, your title will be chief complaint. So there's no need in your box to write CC. It's already going to have a header to it. Now you can see by the red asterisk that it's required. So you need to have that filled out. And then you'll also see that there is an I. So that's your information. So you just hover over that, and the I stands for what information is expected in that box. So the chief complaint is, again, the title of the story. It's the very first most important thing that you're seeing the patient for. So the title of the story. So you want to document to the highest specificity. It needs to have an ICD-10 code attached with it. Rationale behind that is because it's going to be your first assessment and plan. And then if it's an admit or an assumption of care or a readmit, you can put that as well. If it's a follow-up UTI or a follow-up diabetes, you can put that as well. This is not where you're going to put a routine follow-up or a monthly assessment or a chronic condition management. We see patients based on medical necessity. And so we want to make sure that you're not just seeing the patient routinely or for no reason, but that they actually have a diagnosis that we're following the patient for. So everything that we do needs to support medical necessity, because if we get audited, we want our notes to be audit proof. So you have stuff like a RAC, a MAC, a CMS, a JACO, an ACA, all of those audits, all of those people looking at your notes, and we want them to be audit proof. So when they see your note, it explains what's going on. So under your chief complaint, it's going to correlate with the ICD-10 code, and it's going to be your very first assessment and plan. So you see a patient, you think you're going to follow up on diabetes, but you see a blood pressure of 160 over whatever. Now your chief complaint becomes hypertension. Your first assessment and plan would be hypertension, and then your assessment would be unstable. So your chief complaint may complain or may change based on what the complaints are of the patient or based on the information that you're gathering from the chart. So examples of appropriate chief complaints: new admission, status post-UTI, status post-pneumonia, assumption of care, end-stage renal, follow-up depression. The depression has an ICD-10 F3.1, so that's appropriate that you're doing a follow-up. So let's say the PMHNP comes in on Monday and increases the Celexa. 3 to 4 days later, you're evaluating the patient, making sure there's no suicidal ideations, homicidal ideations, side effects. It would be a follow-up depression, and your ICD-10 code would be the F3.1. If you don't know what the ICD-10 is, if it's a mood disorder or an adjustment disorder, pull open that PMHNP's notes and you can read, and they've given you the ICD-10 codes. Same thing with wound care. Same thing with pain management. All of those people are using ICD-10 codes. And if that's what you're following the patient for, absolutely use that. Keep it short, keep it focused. So a lot of people, if you look on the internet, they're saying you're going to utilize the chief complaint as the patient's statement. So in quotes, you could put complaining of abdominal pain for 3 days with nausea and vomiting. Okay, so your chief complaint would be abdominal pain, and under your HPI, then that's where you would put complaining of abdominal pain with associated nausea and vomiting times 3 days. Then your denies diarrhea, constipation, whatever. But your chief complaint, short and simple, and needs to be your first assessment and plan. This box does not carry over from note to note. Your HPI and your assessment and plan all start over again. So all of the rest of your note will pull forward, but these 3 boxes are specific to why you're seeing the patient today. So you may be seeing the patient in a week, and it may be a different HPI. It might be a different chief complaint. So everything needs to be specific and based on why we're seeing the patient today that meets medical criteria. So the box doesn't carry forward. It's based on today. And you may be following up on the same issue. So first assessment and plan would be, or your first, assessment and plan and chief complaint would be UTI. You follow up 4 days later, it would be a follow-up UTI. And then they're having okay symptoms, their dysuria is resolving, and then no side effects. So that's your follow-up. Still the same ICD-10 code, N39, but instead of being a UTI now it's going to be a follow-up UTI. And so your last time you see the patient for this, you could put under your chief complaint, completion of ATB for UTI. So then you're still using the UTI as the assessment and plan code, but your chief complaint would be follow-up resolution. So that's what you're looking for. Hospitalization recap. This is an optional box. The nurse practitioners were seeing that your HPI, they would do a beautiful hospitalization recap, and then the next note, it would disappear, and they were getting frustrated. Well, your HPI is based on today's visit. So yes, it's going to be empty on today's visit and the next days and the next days. So it's empty, but they've spent all this time working on this hospitalization report. And is it a left hip or a right hip? Is it a total hip or is it an ORIF? Are there staples? Are there sutures? So they want to remember some of that. So this was a section that was made. It's not necessary. You can see there's no red asterisk. It is part of the HPI. It does have a header that says hospitalization recap, and it is just a brief information of what happened during the hospitalization of the patient. Okay, so if you remember watching my video on documentation, you'll remember that I did it very short and very sweet. Now, during new hire orientation, it was a little more extensive, but mine was patient at home, patient fell, patient had hip pain, patient transferred to the hospital, patient with fractured femur, patient received ORIF, transferring now to the SNF for skilled physical and occupational therapy, as well as for nursing, pain management, and wound care. So like very short and sweet, but at least it got the story across. In our new hire orientation, it was significantly longer, and there was a big bulky note in there. It's optional to have it in there, so what you put in there stays in there, and it stays in there forever. So what the plan is we're going to put the date in because we want to know when the patient went to the hospital or came from the hospital. So if you're using AI And if you don't know what that is, get with me because nobody should be using AI unless I have a BAA agreement from them. So just make sure you're not using AI without coming through me. If you're using AI, get rid of the date once you've put it into the AI system. If you're not using AI, then you don't have to worry about it. But put either the date of the admission to the facility, post-discharge, or they were admitted into the hospital in May and they didn't come out to the SNF until August, like however long it was. This recap should only remain active for 4 to 6 weeks. So I've seen a lot of hospitalization recaps and I'm trying to search through how long it's been there. And some of them have been there 3, 4, 5 months. So they're no longer a fresh hospitalization. So they don't need to have this section filled out. So until you delete it out, it will continue to follow note to note to note. And that's not what we want. We don't want hospitalization notes from a long time ago. So, and I think anything past 4 weeks is a lot. 6 weeks if you're really going to stretch it, but delete this out. And once you delete it out, it won't carry forward. Your HPI, that is the story of what's going on with your patient. So a portion of that is your hospitalization record. So if you are documenting 4 to 6 sentences about why the patient was admitted and you put that above under the hospitalization record, don't copy it into your HPI. That hospitalization record is part of your HPI. So you don't have to worry about copying it and pasting it and putting in there twice. That being said, once you've got your hospitalization record at the top, this box is going to be the rest of your HPI. And I have seen an HPI. I've seen 2 over the last month or 2. One said patient lying in bed. The other one said patient resting without any new concerns. Neither of those are appropriate. Your HPI is what's going on right now. And if they're resting in bed, that is not a medically necessary visit to see. So what is going on with the patient? So either information that's told to you by the patient, the family, the nurse, the CNAs, whomever is talking to you, how they're feeling, how they're responding to physical therapy, what is occurring in their care, what is relevant. So let's say, and I've had this before, the patient has dementia and can't communicate. Okay. So patient seen in dining room being fed requires total assist with feeding and total assistance with all ADL care. Patient exhibits no signs of pain. Patient's on routine pain medication. Patient participates in activities. Patient, whatever you're talking about, this is where if you do not have a communicative patient, you write observations and statements from others. And if you do have a communicative patient, this is where you document what the patient is saying, how they're doing, how they're feeling, how they're eating, how their therapy is going. That's what needs to go in here. Also, if we're talking about diagnoses, so you're obviously going to see this patient for a reason. One, for an assumption of care. So why is the patient there? And then 2, if it's a follow-up, why are you seeing the patient? Well, a routine follow-up is not appropriate. It's not medically necessary unless there's a diagnosis attached to it. So the purpose is to do a clear, clinical, relevant narrative of why we're seeing the patient and what their condition is. And it also serves as the medical necessity. So when I see laying in bed, I don't see medical necessity there. When I see that the patient has dementia and that they're getting all of this care and that we've monitored the blood sugars and the blood sugars are stable, etc., this is what I'm looking to see. Now, this note, this HPI, does not carry forward either. Rationale is because today's history of present illness is today, it's present. And so if you see them in a week or 2, That visit will be their history of present illness, why they're being seen now, which is why I've got that hospitalization section at the top so that you can remember what's going on. Delete that after 4 to 6 weeks, get rid of that. And then if they go back to the hospital or if they've had a fall and they're getting evaluated, you can put another little note up there. I want a solid, well-structured paragraph, including the current statement or status. And then if there's multiple conditions, let's say you've addressed a wound, make that into a paragraph. And then if you're talking about now their blood sugar, then make that into a paragraph. And then if you're talking about protein, calorie, malnutrition, make that into a paragraph. What you don't want is one big, long paragraph that's difficult to read. Another thing you don't want is a list of negatives. So no shortness of breath, no nausea, no vomiting, no difficulty walking, no difficulty with blah, blah, blah. What we want is negatives to follow positives. So if we're talking about a blood sugar log and the blood sugars aren't stable, you can say blood sugars are elevated or have been intermittently elevated, no signs or symptoms of hypo or hyperglycemia. And so you can list those out if you want. You don't have to. Same thing with hypertension. You can list out whatever they're not having, no chest pain, no chest palpitations, any symptoms, dizziness, lightheadedness. Same thing with urinary tract infection. If you're defining that, you can say that they have dysuria and urgency, but no increased pelvic pain, suprapubic pain, back pain, and is incontinent at baseline. So we're addressing what's going on with the patient. And so just at the very end, don't list a whole bunch of negatives. List the negatives after each positive. And we already talked about patients with dementia, patients on therapy, write a note on how they're doing. We need at least 1 to 2 active diagnoses in your HPI because that's why we're seeing the patient. And do not use this section to list out lab values. So I don't want you to write patient has anemia and their hemoglobin, HCT, MCV, platelet count are this, or the patient has a CMP that was ordered and the results are this, this, and this. If you have abnormalities, you're going to list them under your assessment and plan. If they have anemia and their hemoglobin is 7.2, then you have your diagnosis of anemia, you have your assessment of unstable at HGB of 7.2, and then your plan of maybe ferrous sulfate, and then work up a TIBC, a serum ferritin, a serum iron, and then an occult blood times 2. So, and then a repeat CBC. So any abnormalities that would go under the assessment and plan. Don't use the HPI to list lab results out. So your past medical history actually pulls from point-click care, which is why it's critical that your full medication reconciliation be done before you start this note. So I know this is a very difficult concept. I can see as I go through point-click care that it's not always done. So what I am giving you an example of a patient on Xarelto and the diagnosis is anticoagulant, a diagnosis or a medication of trazodone with the diagnosis of insomnia, a diagnosis of let's say digoxin, and all 8 cardiac medications are all for hypertension. So you need to make sure that the diagnoses are correct. They're all in capitals and they're all associated with an ICD-10. So that might include you going in and adjusting that note to have the correct diagnoses. So if you don't know how to do that, you can get with me. But every medication needs to have the diagnoses in capitals and with the ICD-10 code attached. So that's you editing that medication, putting the correct ICD-10 code in via the magnifying glass, and then saving that note out. Some things that are commonly forgotten are the protein calorie malnutrition, the sarcopenia, the weight loss, adult failure to thrive. So if you don't have the ability to add a diagnosis, and I know some people don't, you can jump into the MedPass section, and there you can add your diagnoses. So you can add the sarcopenia, make a list of them, add them all in, and then you can pick one for that medication for the either MedPass, Ensure, Prostat, whatever you're doing. So not only is it important for the documentation, but it improves patient care and supports correct coding. Because if you're missing all of this and the patient's 86 pounds, how does anyone know that we're not starving the patient, or the patient's not eating, or that we haven't made interventions in putting them into place? So we want those diagnoses to substantiate why the patient BMI is 16 or 18. And so we want that in there. Also, when you put them underneath the medications or underneath the medical history and add those diagnoses, they pull onto your note from note to note to note. So if you think just adding them to True RCM today is going to help, it's not, because next time you go in to do a note and you click that green button, it's not going to pull over. It's going to disappear because you didn't put it in point click care. And this is a section where it pulls over from point click care. Past surgical history is going to be your homework. So this section is frequently overlooked or over-researched, meaning you're telling your RVP that the patient isn't able to communicate, and I spent an hour looking up the social history or the surgical history or something like that. That's not what we're doing. So first of all, if the patient's alert and oriented, we should ask what their surgical history is. We should ask them if they have their tonsils, their appendix, their gallbladder, and their uterus. Some people don't associate those things with surgeries. They're thinking of cardiac surgeries. They're thinking of orthopedic surgeries, and no, they don't remember any of those things that happened years and years ago. So ask them specifically. If they're not alert and oriented, go back through the history, spend a couple of minutes looking at the earliest H&P from the hospital, maybe the last physician's note, maybe a specialist. Sometimes psych is really good on this. Sometimes they're not, maybe pain management. If there's no information available, the patient can't communicate with you, and you can't find this information out, you can write no past surgical history noted. That doesn't mean they don't have past surgical history. It just means that it's not noted here in the chart. Don't leave this section blank. An entry is required, and some helpful hints. So in that past medical history, every now and again, you'll find that the patient has a PEG tube placement and you've forgotten to add that, or a suprapubic cath, or an AV shunt, or a dialysis catheter, or a subclavian line, or you see that they have a compression fracture and they've had a kyphoplasty. Okay, take this. This is your surgical history, the kyphoplasty. So you may have to do some finagling to get a good surgical history, but do it. So it's usually there. That being said, if the patient cannot provide the information and there's nothing available in the chart, don't spend more than 3 minutes looking this up. So I don't want you to tell your RVP, it took me 4 hours to do one note because the patient has dementia and I searched 85 documents. So if you can't find it within 3 minutes, move on. If it's an alert and oriented patient, I'm expecting it to be there. If you didn't ask them the first time, you need to write a note so that, and however you keep track of your patients, so that you ask them PSHX, past surgical history, on the next evaluation. Family history is really important. If you toggle over this I, it will show you what needs to be put into that box. So I'm asking you not to leave it blank because it's required. Don't write non-contributory, which doctors do all the time, so I don't want you to follow their lead. Unknown or reviewed. However, unknown is actually there and as a snippet, because I have had a couple of patients that have had that have been adopted, and their unknown will be unknown forever. It's not like they just don't have that information. They'll never have that information. And reviewed is good for you that you know it, but the reader does not know it. So I'm glad you've reviewed it. Now let's share it and put it in your note. So I want clinically relevant family history that indicates a diagnosis, screening, or anything that we need to do genetic testing. So what I don't want here, and I guess I jumped ahead, is I don't want it to say married, 2 children, 2 grandchildren. Like, I'm not looking for who's in their family. I'm looking for family medical history. So me personally, I write mother. I ask them how old they were when they passed away, and then I ask them what they died from. Same thing with the father. And then I ask, is there any history of cancer, cardiac disease, diabetes, hypothyroidism, or thyroid disease? And then as a psych NP, I ask them, is there any psychiatric diagnoses in your history? And they're all too happy to say, well, I think my mom was bipolar. You're asking if they've been diagnosed as that. But those are important things to be under your family history. Why does it matter? Because if you have a patient that's 300 pounds and they have a significant diabetic history, you may be wanting to draw an A1C on a regular basis. If you have 5 generations of breast cancer, you may want to do a mammogram and screening for this patient. So it shows the pattern, it shows the risk factors of that. So that's a very important section. Now, the social history is one that CMS requires in order to bill for a 99309 or a 99310. They require a comprehensive social history. So I don't want it to say non-contributory, because everything contributes to this patient's care. Unknown social history, that should never be. Or reviewed. Thank you for reviewing it. Now let me know what the answer is to that. So when you put this, when you toggle over this, this is what pops up. So a comprehensive social history should go beyond just tobacco, alcohol, and illicit drug use. It should say multiple things. So in order to do that, marital status, which there are snippets that say married, divorced, widowed, single. Religion, I did not put any snippets. If you remember from new hire orientation, I did not want that to be there. And then previous occupation. And now if you don't know what it is, or they say I worked at Walmart and then I worked at this grocery store, you can just put retail, retired retail. If they've had multiple jobs, they were a trucker, they did construction, that sort of thing, you could just put retired bus driver, truck driver, etc. And then you will address their tobacco, alcohol, and illicit drug use. So tips for gathering information: ask the patient. I ask every patient their surgical history, their social history, and their family history every single visit. It's one of the first couple of things that I establish. Why? So I don't forget. If the patient can't answer because they're unresponsive or they have dementia, then look at the face sheet. That's always a good place to find out their marital status. Half the time you might get a religion out of there. About 2% of the time you might get an occupation, but look that information up. A recent H&P from the hospital might also give you that information. Time-saving rule: if you cannot find anything, do not spend more than 3 minutes searching. Again, if you have an alert and oriented patient, I expect an answer on this. If your patient is not alert and oriented and you can't find it, then it is okay to write not noted because it's not noted in the chart or you were unable to find it. Your allergies come directly from Point Click Care. Just make sure they're accurate and up to date. Verify the allergies. Once you do that, they should be up to date unless they have a new reaction while you're the NP there. Clarify non-drug allergies. And then if the patient has no known allergies, just confirm that. Under code status, that you're going to look and make sure that there is a code status there. If the patient is alert and oriented, you're on your very first assessment, you're going to do an advanced care planning if they're a full code. If they're not a full code, if you've got an alert and oriented patient that is a DNR, we do not do advanced care planning. That was already done and they've already established their advanced care planning. They are a DNR. So verify accuracy with a chart. There was actually a patient that was a full code and I was scanning through and looking underneath documents and they actually had a DNR in place. So I verified with the administration that they were a DNR and then they changed that. So sometimes they'll rescind that. I don't know if they should remove that from the computer. That's a facility level thing. But if they were a full code, then they went to DNR and they rescinded it. Now they're full code again. I might just explain that out here. But again, code status drops in. It should be simple. Your medications drop in directly from Point Click Care. So always just make sure that that reconciliation is done before you start your note. Confirm your dosage, frequency, and route before you even start. Clarify any PRNs, supplements, or newly started medications. And then if medications are discontinued, ensure they're removed from Point Click Care, which they are, because every new note, you're going to pull new information from Point Click Care. If you've got PRNs and you see a whole entire list of PRN medications in the computer, just put them at the bottom. Your diagnosis, maybe cough. Your assessment would be resolved and your plan is going to be to DC the Tessalon Pearls if they haven't used it within 30 days. Rationale behind that is if they've got an issue and we've started them on Zofran or we've started them on a medication, within 30 days, if they're not using it, that should be discontinued. So if the problem arises again, then we know we have a trend and maybe it's something bigger than just having nausea twice a month for, every other month. Your vital signs come directly from Point Click Care. That caveat is it's only as accurate as what's in Point Click Care. So if you do not have accurate vital signs, if they haven't been taken in a month, if they haven't been taken in 2 months, then those are not accurate vital signs. So don't use them. You'll have to physically take them yourself. I know, right? Having to do vital signs, but you want accurate information in the computer. So always check the date of your vitals. Please make sure that they're accurate. Check the date of your weight. Some of the vitals, they may be as of yesterday or today, but your weight might be 3 months old. So if that's correct and the weight is old, just put in parentheses, the weight is from 3 months ago. This is something I've seen multiple times. I've seen patients that have one-time blood sugars from last year, and it will pull over note to note to note. Why? Because they took it once, and it is the most recent blood sugar. So make sure that you're looking at those dates. If there are no current vitals, write an order for us to obtain vital signs. So here's how to write an order for vital signs. You're going to go in, you're going to click other, you're going to write vital signs. It will pull up. This is how I write mine. You don't have to do that, but I want to know if you've got a patient with a blood pressure of less than 110 or greater than 160, or a blood pressure of less than, or a heart rate of less than 60 or greater than 100. I'm going to put it under the TAR. So how to schedule it? I do it weekly. If a patient's on a blood pressure, the blood pressure and heart rate should be obtained daily. in my opinion. It doesn't have to be, but that's in my opinion. So I just went to a routine. I did every day shift instead of a time. I did specific days of the week. I always do Monday so that if they didn't get it by Monday, I can get it by Tuesday. Don't ever do it on the weekends because those don't get done. And don't put it on a Friday because if it doesn't get done, then it really won't get done all weekend long. I just put vital signs here. And then if your supplementary documentation does not pull up your vitals, you click the button and you go in and you click blood pressure, temperature, pulse, respirations. And then if you want a blood glucose, if you want an O2 sat, you can click that. But this is how you're going to order your vital signs. Your weight comes in. If the weight is within the last 3 months, you can put a parentheses around it and then justify why you don't have a recent weight. So if weights are older than 30 days, we're not going to document any weight loss, protein, calorie, malnutrition, or other diagnosis with that weight. If the weights are available, if no recent weights are available, it's difficult to justify clinical decision making. If they're bedridden or hospice, refusing weights, date of the last recorded weight, if you've got one within the last 3 months. If not, don't put anything in there. You need something in there to lock it. So just write patient refused, patient bedridden, patient hospice, no further weights, something like that. And then weight considerations. Weights are important. It helps justify our protein, calorie, malnutrition. It helps justify our adult failure to thrive, our sarcopenia, our weight loss. So it is important to have weights and have them accurate, but make sure that they're current and accurate. That's the one thing about your vitals, is that they might not have been checked on it in a timely manner, and you might have to not only write orders for that, but talk to the DON, the unit managers, and get updated weights. Now your physical exam, the physical exam template is preloaded in there and it's full of a bunch of negatives. Patient's fine, no problems. You want to do the best job you possibly can on your physical exam on your first visit. It might take you a couple minutes longer, but the physical exam goes from note to note to note. So when you get it right the first time, it's easier to adjust the second and third time. So you're going to don't leave it unchanged. Like, don't leave it that the patient's perfect, because then the question is, why is the patient even there? But findings for heat, I see a lot of times aphasia that's not documented, dysphagia that's not documented. When I'm doing your audit, if the patient has glasses and I'm looking right at them and they have glasses on, I'm going to say in your audit that the patient doesn't, you didn't document vision impairment. Hearing loss, if they've got hearing aids, if there's an order to change out the batteries for the hearing aid, I'm expecting you to write hearing loss on there. There's a couple of choices for cardiovascular, adjust that as needed if you've got AFib. Lungs, if they're a chronic smoker or they have been and they've got that chronic cough, make sure you document that. Document other acute findings. I always document at the very beginning of that phrase, mostly, and I do it all in caps so that next time I'm looking through that physical exam, I can actually see what's going on. Chest, if you've got a pacemaker, I expect it to be documented. Subclavian, dialysis catheter, central line. GIGU, do not leave it blank. You have 4 choices. You have continent, you have incontinent, you have catheter, and you have ostomy. Out of the catheter, you have Foley or suprapubic. And then out of the ostomy, you have urostomy, ileostomy, or colostomy. Those are the 4 things I'm looking at. I don't want you to leave it blank. When you leave it blank, I will bring that to your attention during an audit. And then don't write deferred, don't want to look at their genitalia. I'm not asking you to. That's not what this question is. What I'm asking is for their bowel and bladder habits there. Extremities, we've got a couple of good snippets in there. But if you see muscle weakness, sarcopenia, muscle wasting, any diagnoses up above, put that in there. Contractures, a lot of people put extremities normal, and I look up under their medical diagnosis and they've got contractures, they're paraplegic, they've got a CVA with right-sided weakness, or hemiparesis. So that is the stuff I'm looking for under the extremities. Skin, I've got about 6 different snippets in there. Whether it's from vascular insufficiency, hemosiderin staining, weakness of the skin, tensile tissue. So any of that counts. Senile purpura, any kind of bruising related to an anticoagulant, an antiplatelet, that is all in there. Psych, do not write in your HPI that patient is crying, sad, and tearful, and then just leave your psych as calm and cooperative. Make sure your notes are consistent with your physical exam. Again, if you write them in the beginning, it reminds you the next visit to adjust them. And then neurological. So most, and I don't mean all, but most nurse practitioners leave that as no neurological deficits noted. So I will look at your BIM score and I will see that if it's 7 or below, you should be having short-term and long-term memory deficits. If it's between 8 and 12, you have short-term memory deficits. And if it's 13, 14, or 15, then you can leave the no focal deficits. But this is your neuro. Neuro is dementia. So this is where you're going to put tremors. This is where you're going to put memory loss. This is where you're going to put anything that's neurological, TBI, with whatever is going on with them. So best practices, make sure that your HPI matches your assessment and plan, matches your physical exam. Those all are important. So if you're documenting it under the HPI as crying, sad, and tearful, please make sure you're adjusting it down here. This is one of my biggest time spent doing your audits. I'm looking specifically at this physical exam. It's very important for that to get right. Why? Because we're clinicians and that's what we're supposed to be doing. Labs, you notice there's no red asterisk. You don't have to put anything there. If you hover over this blue eye, you'll see that labs are looking for date of service and lab reviewed. That's it. Any significant findings that need to be addressed, you're going to address under assessment and plan. So if you have a TSH of 10, don't write January 1st, 2025, TSH 10. I just want you to write TSH. So your assessment and plan would then be hypothyroidism, your assessment would be TSH of 10, and then your plan would be to initiate levothyroxine. So anything within the last 30 days for a new assumption of care, that's what you're looking for labs. Don't go back 2 months, 3 months, 5 months, 10 months. Now you can use information from that. If your A1C is 2 months old and you're documenting on diabetes, you can write last A1C, whatever it was, 8.5. But don't write that you're reviewing labs from past 30 days. And if you saw them 2 weeks ago, your labs then go from today to 2 weeks ago. And there's that short span that you're going to do. And if you only saw them 5 days ago, then that's even smaller. And so the labs that you can review are from the last 5 days to now. Okay, so only from visit to visit. And when you do your initial, I only want the last 30 days. Document labs that are drawn since the last visit. Your assumption of cares are the last 30 days. If you're using AI, remember to remove the date before you add it. Do not document in individual lab values here. If the labs are abnormal, address them in your assessment and plan. If a lab value is needed to support a diagnosis, you may reference it in the HPI or assessment and plan, but not in this section. And then always list the date the labs were drawn. So if you reviewed them 3 days later, that's not the date. The date of service is the date the lab was obtained. So labs reviewed CBC and CMP drawn on 8/15/2025. You would not write no new labs since last visit. Rationale behind that, it's not required. So this section will not even populate in your note if you are not reviewing labs. Same thing with next labs pending, if it's not required. So if you don't have any labs pending, then you don't put anything in here. But if there are labs pending, whether you ordered them or not, put them in there. If there are labs scheduled every quarter, like a Depakote or an ammonia level, don't do a Depakote without the ammonia. And they're every quarter, go ahead and put them in there. Anything that was ordered by other providers, if it's pending and they haven't gotten it done, that's a lab that's pending. So labs, you've got a lipid panel ordered due on 9/30. Remember, if you're AI, take that date out. Quarterly CMP, a chest x-ray ordered by cardiology on 8/20. Delete the date if you're doing AI. If you're not, don't delete the date. And then your B12 ordered and then patient refused. So remember, when you're documenting a 99310, you're usually going to have to read a lab, add a lab, read someone else's note. So that could be psychiatry, that could be wound care, that could be anyone that is outside of the facility. So usually you're going to need those three, and then the collaboration, which is free. We do collaboration on every patient. So remember, if you're pulling that 99310, we're going to want that data to substantiate that. Your assessment and plan, it is required, and if you hover over this blue eye, it will tell you that the primary diagnosis, the reason for the episode, the chief complaint, should be documented first, followed by other findings. So first, how to document on it. Your first word is going to be your diagnosis. You can use the ICD-10 code if you want. So it could be N39 UTI. Then you're going to do the assessment of the diagnosis. Please remember, it is not the assessment of the patient. It is the assessment of the diagnosis. So the hemoglobin or the anemia is unstable if the hemoglobin is 7.2. So your diagnosis is anemia. Your assessment is a hemoglobin of 7.2, and your plan is going to be initiate ferrous sulfate, draw a TIBC, a serum ferritin, a serum iron, an occult blood, redraw CBC in 2 days or whatever you want to do. But that's how you're going to do that. You're not going to say anemia patient stable because their hemoglobin has been 9 for 3 months. The patient is stable. The diagnosis is not. And under the assessment and plan, you're assessing the diagnosis. So someone with chronic kidney disease with a GFR of 30 is not stable. How long can you sustain with chronic kidney disease without morbidity, mortality, especially if you're diuresing them? So you're looking at the assessment of the diagnosis and then the plan. So chief complaint comes first. Every medication must be addressed in your first assessment and plan. After your first admission note, you need at least 3 to 4 active conditions to support medical necessity. So 3 to 4. So if you've got a cough and then you've got, let's say you've got COPD, but the patient's also on a dysphagia diet, you've got 3 right there. You've got a healthy assessment and plan. Remember the medication reconciliation before you start. And then remember that the medication used has to be FDA approved, which means if you're using trazodone for insomnia, you're going to have to, during your medication reconciliation, you're going to have to use the diagnosis to depression, because that's what trazodone is utilized for. You can also click the G4 7.00 insomnia, and it can say depression and insomnia. I don't have a problem with that, but you have to have the FDA approved diagnosis. So you've got poor PO intake, weight loss, and your diagnosis. You're going to put depression. You're going to put poor PO intake. You're going to put significant weight loss. And then you're going to have your diagnosis for Remeron as depression. And then you can put like weight loss as a diagnosis, or poor oral intake, whatever you want to associate that with. But you have to have it under the FDA approved. That's one thing that the nurses don't always get right. And so that's why you're doing the medication reconciliation. Or they don't know why they're on an anticoagulant. They just see that it's an anticoagulant, so they put anticoagulant. That's where we're coming in and changing that. Use snippets as a guide only. You've got a lot of assessment and plan snippets. Use it as a guide. Please edit, adjust, delete, rearrange your snippets that are the same and that you copy from note to note to note. And hypertension always says the same thing. Looks like a copied and pasted note. That being said, Medicare is not going to reimburse you for a note that is the exact same as the last note. Even though you saw the patient, even though you really did do the review, if the note says the same thing, then it's not medically necessary. You're going to list unstable or severe diagnoses at the top, anything with a medication change, adjustment, or lab order, and then anything not anything that's stable. So what you don't have to include, because I just told you, you're going to include every single medication on your new assumption of care. Don't include your bowel protocol. Don't include your Tylenol. Don't include routine vitamins. Now, your vitamin B12, your vitamin D3, you will be doing labs following that. So you would want to include that. So step by step for assessment and plan, start with your chief complaint. It has to have an ICD-10 code with it. Then you're going to address unstable or high priority conditions, which my hope is that your chief complaint is an unstable or high priority condition. Any diagnoses that require labs or med changes would be next. Any stable chronic conditions, and then meet the minimum. So on your first note, it's every condition. After that, it's 3 to 4. And then exclude your non-essentials. So if you've got lactulose, Miralax, Senna, and Colace, and they're all scheduled, yes, by all means, put constipation in place. But if you're only on a bowel protocol, you're only on routine PRN, Tramadol, or Tylenol, because that's a standard order and diagnosis, then don't put that on there. And your multivitamins, your cranberries, your vitamin C, none of that needs to be put on your first assessment and plan. Now, if you choose not to do the way I said, and so I said you've got your diagnosis first, and then your assessment, and then your plan. If you choose to do it by MEAT, and if you don't know what MEAT is, you're going to see, I'm okay with that too. I'm not a fan of MEAT. I don't use MEAT, but you can do it. So MEAT is monitor, evaluate, assess, and treat. So again, you're going to put your unstable conditions first. So your diagnosis is anemia and it's unstable. So you're going to monitor. So your monitoring of the last CBC showed that your hemoglobin was 7.8. You evaluate the patient. They are fatigued, pallor observed. You assess, likely multifactorial, anemia remains unstable. And then you treat. You're going to do ferrous sulfate and get a CBC in 1 week. So if you want to use MEAT, you can. If you want to do the assessment and plan, you do the diagnosis, the assessment, and then the plan. Consultation collaboration required for every note. You can see the red asterisk here. Why does it matter? Well, because CMS says if you're billing a 309 or a 310, you need to have collaboration. Why would we ever go into the building and see a patient and not communicate with someone? Whether it's the nurse, whether it's the CNA, your documentation going into point-click care, we should be talking to the staff at the facility. If you're doing referrals, coordination of care, family discussions, stuff that takes up time, you'll definitely want to add that into the collaboration section. And there are snippets that you can use and adjust. Your time and medical decision making. I want it to be clear that time can be used or medical decision making can be used. It is not both. It is either or. So the first thing is the required snippet that says time. The time of the note does not necessarily correlate to the time or the date the patient was seen. So you do your rounds today. Today is, let's say, Monday. You do rounds on Monday at 8 o'clock, 9, 9 o'clock, 10, 10 o'clock, 11, 12, 1. You go home, take a nap. Good for you. Eat your lunch, walk the dog, buy dinner for tonight, get the pot roast going, and then you sit down to document at 2 o'clock. You didn't finish documentation, maybe that was the nap that caused that, until tomorrow. So this is saying when it drops into point-click care tomorrow, that it's not necessarily tomorrow that I did the note. It might have been today, and it might have been earlier this morning when I rounded. So you don't have to put the exact time. Otherwise, you'd be like 8:05, 8:20, 8:24, whatever. And so you don't want to keep track of that. If you're documenting by time, and I'm recommending time for everyone unless you're using AI. If it's a new patient, then you can utilize an extensive chart review was completed, and that does allow you to use the 45 minutes. So every single new admit, every single assumption of care, every single readmission should be billed at 45 minutes and a 99310. You should be taking the time to look at why the patient was hospitalized or what the patient is there for. You should be looking at labs. You should be doing medication reconciliation. And if it takes you less than 45 minutes to do all of that, you need to call me because you're missing something. So for follow-up notes, if you're billing at 45 minutes, you have to have justification of where you're getting that 45 minutes from. So your assessment and plan says hypertension stable, AFib stable, GERD stable, constipation stable. Where did you spend that 45 minutes at? They're going to ask CMS, RAC, MAC, JACO. They're all going to ask, why did you bill 45 minutes if you don't have it identified? So under HPI, there's a smoking cessation education, which if they don't want to stop smoking, you can use that on visit number 2. And it just is a long discussion on smoking cessation, the importance of it. You understand they don't want to quit smoking, but you're giving them the education. If you are going over advanced care planning with a patient, as far as it's a follow-up note, it's a 309, and you want to do advanced care planning again because maybe the patient got COVID and they're really sick and you're going to do it again. Although I'm not sure a COVID would definitely be a 310. So I'm not sure. But if you're just doing a regular visit and they say, hey, I was really thinking about advanced care planning, instead of billing advanced care planning, you're going to bill a 309 plus advanced care planning. That will bring you to a 310. So you only bill in advanced care planning if you're at a 310. If you're at a 309, use that time to bring you to a 310. So make sure if you're using 45 minutes that that's justified. Do not use time and MDM. If you're a nurse practitioner that is not using AI, I want you to use time. If you are using AI, I want you using MDM. easier that way, more efficient, less risk of kickback. Then after that is your ICD-10 codes. They have to be in the exact order of your assessment and plan. So whether you have to take a Post-it note and write that down, it doesn't matter. It needs to be in the exact order. So you're going to come here to the add button. Don't go to add to favorite, go to add. And this is where you're going to list all of your ICD-10 codes. And they do pull over from note to note to note. And they do toggle up and down. So if you don't put them in the right order and you're wanting to rearrange them after you've got them, you can. Your CPT codes are a little bit different. They are under the add favorite. So if you go to the add favorite button, it will pull out your discharges, your advanced care planning, your smoking cessation, and your evaluation and management. So all of your add favorites is a good place to go. So you're going to use the add favorite if the patient is Medicare. So it's going to say Medicare, it's going to say Medicare A, it's going to say Medicare Advantage, it's going to say Medicare Blue Cross Blue Shield, it's going to say Humana Medicare. If it says the word Medicare, it's Medicare. It is considered an SNF. And under your CPT codes, there will be two different choices. There will be the LTC or the SNF. Anywhere in the title of why they're in the facility today, if it says Medicare, it is SNF. This came out in July. It's been a problem for many, many years. It's been a protocol for CMS. In July, they said, if you don't get this right, now you're not getting paid for it. So no longer is this really important. This is super important. If you code this wrong, that will not get paid for. So if it says Medicare anywhere on their current stay, the reason why they're there, their census for the facility, their SNF. If they're anything else, if they're Medicaid, Medicaid pending, hospice, respite, Blue Cross Blue Shield, managed level, anything other than that word Medicare in there, and it's got to have Medicare somewhere. If they're anything else, they're LTC. If they're there on Medicaid for 3 weeks for IV antibiotics, you would think they're short-term care, and they are. They still fall under the LTC heading, okay? Here is the MDM chart. It talks about complexity. Definitions, I want to add this. This was copied directly from CMS, but I want you to know that these definitions are based on the diagnoses. So if we're talking about a stable chronic illness, we're talking about an illness that is stable and as at goal. So if it is unstable, if it's not at goal, if it's not where it needs to be, if it's progressing, if they have CHF and now they have 3+ edema instead of 2+ edema, we're talking maybe the patient's stable, they're having no shortness of breath, they're having no changes in anything that's going on with them. They've got a chronic illness with an exacerbation. Something's going on. If you have a GFR of 40 and this month it's 32, you have a chronic illness with progression. That is unstable. The patient may be stable. Vital signs look good. They're having no problems. They don't have any swelling. Everything looks good, but their GFR is dropped. My assumption is their BUN and creatinine would be off as well. But if you have that and the GFR is getting worse, they have a progression. If you have an A1C of 8.5, you've got an unstable chronic diagnosis. So is it poorly controlled? Is it progressing? Is it acutely worsening? What are we talking about? We're talking about the diagnoses. So when you're looking at this, make sure that you're looking at the diagnoses for that. So that's my information about documenting a progress note. This is what we went over in new hire orientation. Sometimes it's hard to remember, as we're going through a 2-hour writing a progress note. So I've made this specifically so that you can go back and look at that. I hope this is helpful. If you have any questions, of course, you can email me, you can text me, reach out, let me know. This was made to be informational, and I hope it helps you. If you have any questions, let me know, and I hope you have a great day.